Professor NISHINO is the director of Department of Neuromuscular Research, National Institute of Neuroscience, National Center of Neurology and Psychiatry. He's also appointed to the director of two departments in the Medical Genome Center in NCMP. Currently, he is also a guest and visiting professor at 4 universities. And so he actually graduated in 1989 and joined the neurology fellowship training for 5 years under Professor Jin Kimura. Therefore, he is not just a scientist, he's also a clinical neurologist. After then, he pursued his research in the muscle histology and has been under fellowship training in Columbia University, where his research was guided by Professor Ichizo Hirano and Salvatore Di Malo. He was appointed to Section Chief in NCMP in 2000, and now is the director of the center. His center received more than 80% of all the muscle histology samples from Japan. So actually, I would say that majority of the musculoskeletal histological diagnosis were made by Professor NISHINO and his team. He is also a very expert in teaching. He's a very good teacher, has been traveling around in many countries, including mainland China and Hong Kong, to give different lectures, both in the histology and the clinical aspect. Today, he will tell us the diagnosis of Pompe disease and its differential diagnosis. Professor NISHINO, please.
So today I'd like to talk about the Pompe disease and its differential diagnosis. Okay. So this is my disclosures. So as you probably all know, the Pompe disease is caused by the deficiency of acid alpha-glucosidase. It's sometimes called acid maltase, but now I think especially adult neurologists used to call acid maltase, but the name acid alpha-glucosidase is more widely used nowadays. And this enzyme is encoded in GAA gene, and so far more than 750 disease-causing mutations, or you can say mutations, are listed. So there are, of course, enzyme replacement therapy, or ERT, is available. That's why I'm here today. And as you know, acid L-glucosidase alpha and aval-glucosidase alpha, I understand that those two are available here in Hong Kong. Okay, so but I will mainly talk about the diagnosis and differential diagnosis, but I don't go into the therapy today. Okay, so yeah, so of course there are actually two major classifications. One is infantile onset, childhood onset, adult onset, or it is also, well, can be divided into two forms, IOPD and LOPD. Well, so no matter how you divide, actually this is actually a spectrum, and the borderline is often so clear, right? But infantile onset cases are very, well, they usually show prominent hypertrophic cardiomyopathy. And this is, so when pediatricians find hypertrophic cardiomyopathy in floppy infants, they, I think, almost immediately think about the possibility of Pompe disease. Okay. So they are floppy like this. And you can, as you can see, the line here, they often develop accompanied liver hepatomegaly as well. And as I mentioned, the cardiomegaly is prominent. And then, so that I really doubt that if the well-trained experts, I mean the pediatricians, see this type of patients, I doubt that any patient will be overlooked. But the problem is in LOPD. LOPD is characterized by proximal muscle weakness and respiratory failure. But proximal muscle weakness is seen in all types of actually muscle disease. So in a sense, there is no characteristic features. Of course, respiratory failure is really important, but in terms of muscle weakness, the pattern of muscle weakness may be not so well characteristic. So yeah, and this shows the muscle CT of 3 different patients. The left side, you can see, this is in the early stage. You can see the distal leg muscles are well preserved, but thigh muscles are already affected, and paraspinal muscles as well. And if this, the disease progresses a little bit, then you see more atrophy in thigh, and now you see a problem in the hip level and paraspinal muscle as well. In the advanced stage, except for some muscles, almost all thigh muscles are already completely replaced by fat. And this is also the case in hip muscles, especially in gluteus minimus and gluteus medius muscle. And paraspinal muscles and rectus abdominis muscle are completely gone. So the pattern of muscle involvement is, yes, truly proximal. And when it comes to muscle pathology, well, in infantile onset cases, almost all muscle fibers you see vacuole, intracytoplasmic vacuoles like this, big vacuoles with something amorphous, basophilic amorphous materials inside. And if you perform acid phosphatase, which is one of the lysosomal enzymes, and if you perform the histochemistry for acid phosphatase, all those vacuoles show high acid phosphatase activity. It means that those vacuoles are lysosomal in nature. In fact, those vacuoles are lysosomal origin and originated from lysosomes. Because the excuse me, acid alpha glucosidase is one of the lysosomal enzymes. When it is deficient, actually lysosomes try to compensate its deficiency. Of course, it cannot, but because of this compensatory mechanism, other lysosomal enzymes will be upregulated. That's why the acid phosphatase activity is very much high like this. So this is actually diagnostic. Of course, even on H&E, I think you can make a diagnosis because this is really typical and unique pattern of pathology. But if you do acid phosphatase, you can confirm its lysosomal nature. So I think the diagnosis is can be confirmed. So in child onset cases, the number of muscle fibers with vacuoles will be decreased, but still you can see scattered fibers with vacuoles. And again, in many vacuoles, you can see something basophilic in color and amorphous in nature. So actually, the nature of vacuoles are the same, but the number of myofibers with vacuoles is decreased, and much fewer than infantile onset Pompe disease. But still, I don't think you'll miss the diagnosis if you see this type of pathology. And of course, this is a glycogen storage disease, and the glycogen is accumulated within the vacuoles or within the lysosomes. And this can be well demonstrated if you do PAS staining, but you have to be a little bit careful about it because for muscle pathology, we usually use frozen muscles. And if you just do PAS, again, frozen muscle, actually glycogen will be washed out. So you have to use, for precise evaluation, you have to use glutaldehyde fixed muscle, which is actually basically for electron microscopic analysis. Then glycogen will not be washed away. This is actually the section made from glutaldehyde fixed muscle. Then you can see within the vacuoles, see glycogen is clearly accumulated. So this is again confirmed the nature of the glycogen storage disease nature of the disease. But the problem is adult onset cases. You can see there is no such vacuole at all. Of course, some cases you can still see 1 or 2 fibers with typical vacuoles. But in this particular case, all over the specimen, all over the section, I didn't see any typical vacuole. But the only one here, this one has small vacuole. This is not really the vacuole which is typically seen in Pompe disease. It's more like what we call rim vacuole. So I don't think you can make a diagnosis just by this picture. Nevertheless, because enzyme replacement therapy is available, you should never ever miss the diagnosis, right? And also you should make a diagnosis as early as possible, because the number, increasing number of papers suggest that early therapy will give you better prognosis, right? And for this, of course, as you know, the dried blood spot test, DBS, is very useful for screening. And I heard that this DBS screening program is available here in Hong Kong. So I think if you have any suspected patient, you should cast a wide on it, because it's a little bit not so, the clinical pathological phenotype is not really, outstanding. So you should cast a wide on it. But still, of course, if you see any patient with proximal muscle weakness, high CK, or even non-specific pathology, well, you should think about any possibility of Pompe disease. Okay. But I understand here the audience is not the general physician. I think you are somehow specialized in neuromuscular disorders. For specialists, I think you need go further. Well, you shouldn't just say, oh, proximal muscle is non-specific, right? I think that's not enough. I think we should, more carefully evaluate the patients, okay? So that typically non-specific or not. Okay, I'd like to discuss proximal weakness. So in many textbooks, especially for medical students, say that, okay, in muscle disease, proximal muscles are predominantly affected. In neuropathy, distal muscles are predominantly affected. Well, this may be true, but let's see this one. So this is a video from Duchenne muscular dystrophy, okay? You know this sign, right? Goward's sign. Of course, I know you know. But something I really want to ask you is, which muscle is most severely affected when patients show this type of maneuver? Actually, for this, okay. So when you stand up from the sitting position like this to this, you have to extend 3 joints: ankle joints, knee joints, and hip joints, right? But let's focus on 2 major joints for hip and knee joints, okay? To extend hip joints, actually you use gluteus maximus muscle. To extend knee joints, you use quadriceps muscle, okay? All right, so I actually analyzed this video frame by frame, okay? From this position to, finally to stand up, he took 2.7 seconds, okay? Very interesting. After just 0.1 second, he already extended his knees, right? Then for all the remaining time, he took all the remaining time to extend his hip joints, right? So it means that he had difficulty extending his hip joints. So this Goward's maneuver indicates difficulty extending hip joints, right? Okay, I will show you the video again. It will look different, okay? Exactly the same video. He already extended his knee joints, but it took a long time to extend his hip joints, right? It looked very different, right? Even the same video. So it means that once you understand the mechanism, the patients will look different. This is very important. And if you look at the MRI of the patient, unfortunately, I don't have the MRI of this patient at that moment, so I will show you different case. But interestingly, look at this one. Gluteus maximus muscle is very white, right? On T1 weighted image, fat is white. High intensity, as you can see from the subcutaneous fat, is really white, right? The hip muscle is really, you see a lot of white color. It means that gluteus maximus muscle is significantly, infiltrated by fat. In contrast, look at quadriceps muscle, almost normal. So this is perfectly compatible with his maneuver, right? So this is actually very important. So nowadays, the importance of muscle imaging is really, increasingly recognized. And comparison between muscle imaging and your clinical observation will be very helpful to better understand your patients. And in fact, if you follow Duchenne muscular dystrophy patients, year by year with muscle imaging, you see even in the early stage, gluteus muscle is a little bit affected and more affected. But quadriceps is affected later, right? So again, comparison between imaging data and motor function, you can learn a lot from this comparison. Okay, let's practice more. Of course, this is not Pompe disease, but this is limb-girdle muscular dystrophy, R1 or 2A, which is caused by calpain-3 gene mutation. So let's discuss which is weaker, hip extension or knee extension, okay? Very difficult, right? Because he already has knee extension, problem in knee extension, but looks like he has more difficulty in hip extension because he had to take and use his hands putting on his knees, right? So look at this one. This is again a different patient, but see, hip muscles are more affected, gluteus maximus, and at this stage at least, the quadriceps muscle is well preserved. So this MRI, the patient of this, which I took MRI, is in the earlier stage. That's why the quadriceps muscle is well preserved. But anyway, so the pattern of muscle involvement is somehow similar to Duchenne muscular dystrophy. So hip muscle is more affected. Okay. Anyway, so now we know that so again, in the textbooks, they say that proximal muscle is predominantly affected in muscle disease, but not uniformly affected. Actually, very much selective. Okay, not all proximal muscles are equally affected, and this pattern of muscle involvement is different from disease to disease. Okay, and understanding by recognizing this pattern, maybe you can make a diagnosis, or at least you can narrow down the differential diagnosis. So again, that's why now the importance of muscle imaging is being, getting more and more increasingly recognized. Okay. All right. Then, of course, you have to think about LOPD patients. Okay. This is difficult. He will do it again. Tricky, very tricky, right? Yes. Then, if you look at, actually, it's very tricky. I will show that again. Oh, sorry. I will show you again. Actually, he does, at least as compared with Duchenne muscular dystrophy, he doesn't have much problem with extending hip joints. I think that's something you can say. And if you look at the MRI, see, gluteus maximus muscle is at least, of course, eventually everything is affected. But until certain stage, actually gluteus maximus muscle is relatively well preserved, while quadriceps muscle is affected. So of course it depends on the stage, but at a certain stage you'll see more abnormality in the abnormality in knee extension than hip extension. But if you focus on hip level, gluteus maximus muscle is preserved, but gluteus medius and minimus muscles are significantly affected, right? So, gluteus medius muscle is for hip abduction, right? This one. So this movement should be affected. And also adductor magnus is affected very early. right? So should be, they have problem closing the leg. So when they walk, can be open wide like this. So if gluteus medius muscle is affected, of course, the pelvis will not be stabilized. So, their pelvis will be, fluctuating like this when they move, when they walk. So this is called waddling gait, yes, or Trendelenburg sign. Okay. So this is one of the LOPD patients. You can see the way he walks. So he opens his legs, right? Right. Yes, and also hip is, fluctuating like this, right? So this is the video from Sanofi, and this, the subscript is in Japanese, but it will be in English, so you can. I hope you can hear the sound.
Late onset Pompe disease, or LOPD, is characterized by progressive weakness in the trunk and proximal muscles, as well as the group of muscles surrounding the pelvis. One of the visible symptoms of LOPD is a recognizable walk or myopathic gait, which is characterized by its waddle-like appearance. Some patients with Pompe disease may be more severely affected or have a longer disease duration. Brian is a 44-year-old man with LOPD. His gait abnormalities are caused by weakness in his proximal muscles and pelvic girdle. Notice his unsteady gait, slower pace, and shorter than average stride length. Brian has difficulty stabilizing his pelvis as he walks, causing him to shift his weight onto one leg as his pelvis drops on one side and comes up on the other, reflecting a waddling gait characteristic of Pompe disease. He also positions his hips forward and curves his back inward to maintain balance. As Brian turns to walk in the opposite direction, he shuffles both feet slowly because it is difficult to maintain balance on one foot.
His hip is like this, right? Pelvis.
If you notice any of these gait characteristics in your patients, consider a GAA enzyme assay or genetic testing to test for Pompe disease.
Yeah, so actually I took one frame from this video. So clearly the level of pelvis is not really horizontal. They move fluctuating like this. This is compatible with significant gluteus medius minimus involvement. Okay, so again, the comparison between your clinical observation and muscle imaging data will be very useful. Yeah, and you can learn a lot from this. Okay, and one of the other features you often observe in LOPD patients are scapular winging. But even the experts, when they see scapular winging, they almost immediately think about FSHD, facial scapular muscular, humeral muscular dystrophy, because scapular winging is one of the very important features of FSHD. But is it the same scapular winging or not? Yes. So in this case, you can see, first of all, paraspinal muscles are really atrophic. Actually, everything is atrophic. And you can, if you see scapular, actually the muscle covering the scapula is also atrophic, very thin. And also this is, you can see like a space here. This is also because the internal muscles are also atrophic. Okay, but anyway, everything is atrophic. And well, there is some study, the imaging study for LOPD patients. Actually, all those supraspinatus, infraspinatus, subscapulars, all are well, you can call periscapular muscles. I mean, the muscles attached to the scapula. All muscles are affected, actually, gradually. In the advanced stage, all muscles are affected. So you can compare with LOPD and FSHD. So this is CT. So on CT, you can see normal muscle is gray in color. But look at this one. In LOPD patients, subscapularis muscle is dark, right? So if you look at this, paper, subscapularis muscle is the earliest affected muscle among all those periscapular muscle, right? This in the early stage, already 80% of patients show subscapularis muscle involvement. And in fact, if you look at this patient, subscapularis muscle is already completely gone, while other muscles, of course, atrophic, but still there. FSHD, subscapularis muscle is never affected, never affected. But trapezius muscle is almost always affected. Actually, there was very important paper from European group. They said that if you see trapezius muscle involvement with spared subscapularis, muscle, then you already have diagnosis of FSHD. So muscle imaging is very useful, right? Right. So again, scapular winging, not equal FSHD. You should evaluate more carefully. Okay, then respiratory failure. I said the respiratory failure is one of the prominent features of Pompe disease. This is because of prominent diaphragm involvement. So this is an autopsy muscle. This is from the same patient. Tibialis anterior muscles almost normal, look almost normal. So she died already, but the tibialis and distal leg muscles also normal, look normal. But look at diaphragm, almost no muscle at all, right? So you can easily tell with this, almost no muscle. I think that with this diaphragm, I don't think she can breathe at all, right? That's why she died. Now, we had a small study many years ago, almost 10 years ago. And we had, at that time, we had 5 late onset Pompe disease. Actually, they are really late onset. You can say adult onset, actually. The youngest one is like 32. So I think they are really adult cases. Well, of course, the onset maybe two of them onset in childhood, but anyway, they are all adult patients. Interestingly, and I highlighted 2 lanes. The upper one, highlights the age when they started ventilation, with ventilatory support. And the lower one highlights the age when they started using wheelchair, right? So the highlighted yellow is earlier one. So it means that half of them, they started using, support, they needed ventilatory support while they are still ambulant. So this is a small study, but I think the published data from all over the world are almost the same. Really, 50% of patients needed respiratory support while they are ambulant. This is very unusual for muscle disease. For almost all muscle diseases, well, respiratory failure come when after the patient lose ambulation. So this is very in a sense very unique. But there are several muscle diseases in which you see early respiratory failure. So of course, one of them, very important one, is late onset Pompe disease. But others include Nemaline myopathy, hereditary myopathy with early respiratory failure, or HMARF, which is caused by mutations in one specific exon in titin gene. And others are rigid spine muscular dystrophy caused by mutation in selenin gene and or MEGF10 mutation. And also there are cases with the acquired condition. Some acquired muscle disease can also cause respiratory failure, like sporadic late onset Nemaline myopathy, although I don't go into the details today. Okay, so when patients have respiratory failure, of course, some patients may tell you that, okay, I have problem breathing, but not always. This is not always the case. They may complain something else. For example, if you have ventilatory problem, of course, CO2 will be, retention, right? CO2 will be, carbon dioxide will be increased in your blood. And especially while you are sleeping, right? So the maximum carbon dioxide level is in the early morning. Will be in the early morning. So that's why the blood vessel will be extended in the in the head, and which will cause morning headache, right? So patients may come to you complaining headache in the morning, or maybe sleep disturbance, or loss of appetite, or they may complain, well, the sleepiness during the daytime because they don't sleep very well at night. So it's a little bit tricky. This paper is very interesting. This is a just picture section of neurology, Journal of Neurology. They highlighted, as you can see by the arrow here, they emphasize the importance of paraspinal muscle involvement. Indeed, paraspinal muscle is affected as compared with normal one. But they missed very important finding. They didn't say anything about it, but there is very important finding here. This one. What is this? This is diaphragm. See? Very, very thin, right? As compared with normal one. But they didn't notice it actually. So if you take, MRI, the CT, actually you can also evaluate diaphragm like this, right? Diaphragm atrophy. And indeed, I mentioned that HMRF, rigid spine, and MLE myopathy, and all those myopathy, you can see the diaphragm is thinner than normal, yes. So if you want to evaluate the diaphragm, actually the best position is an aortic hiatus. And typically it is a T12 level, but of course you need some range. So maybe you may want to make a section from T11 to L1, something like this range. You can observe that diaphragm. Then I'd like to discuss a little bit about muscle pathology. There was a very interesting paper there a long time ago. This paper was published. Though this disease, unique disease, was originally reported as lysosomal glycogen storage disease with normal acid mass test. There are glycogen storage disease, but there's only one lysosomal glycogen disease, which is Pompe disease. Because all other glycogen storage disease, enzyme, deficient enzyme is local, present in the cytoplasm. The only acid alpha glucosidase is present in the lysosome. So lysosomal glycogen storage disease means Pompe disease. As I mentioned, acid maltase, it means acid alpha glucosidase. So it means this is a very tricky name. Pompe disease, but acid alpha glucosidase is normal. Very tricky name. Yes. But this disease is now called Danon disease because the first author is Danon, Dr. Danon. Yes. But I have to, for the sake of the Professor Di Mauro, who I learned from, I have to tell you, actually, this paper was mostly written by Professor Di Mauro. And Dr. Danon and Dr. Shin, they sent sample to Dr. Di Mauro, and he described everything. But he was so kind to put the clinicians in alphabetical order, Danon and O, okay? So in a sense, of course, I don't say that Dr. Danon didn't do anything, but actually most of the work was done by Dr. Di Mauro. But now this disease is called Danon disease. So I guess Dr. Di Mauro is not that happy about it. Anyway, so this is called Danon disease. And Danon disease is an X-linked disease. Now it's known to be caused by, the LAMP2 gene mutation. But anyway, all males are affected, and also many of the female carriers are also affected. And all patients show cardiomyopathy, and many patients, and actually most of the patients also show myopathy and some mental retardation. So if you just pick up the words cardiomyopathy, myopathy, and vascular changes, it sounds like Pompe disease. That's why it is, it was originally reported as lysosomal glycogen disease. But clinical features are different because the onset is teens, right? So childhood onset Pompe disease, usually don't show cardiomyopathy at all. So actually clinical features are different. And also muscle pathology is very different. Well, in the original paper, they said that there are vacuoles like similar to Pompe disease, but it's not. So again, the Pompe disease, you see typically huge vacuoles, but in Danon disease, you see only tiny vacuoles. And these vacuoles are very interesting. Actually, they have the vacuolar membrane has sarcolemmal features. Sarcolemma means muscle fiber membrane. So if you do, for example, if you use dystrophin, if you do immunohistochemistry against dystrophin, these vacuoles have dystrophin in the vacuolar membrane for some reason. So that's why we named this one autophagic vacuoles with unique sarcolemmal features. But I don't go into the detail, but which is not seen in Pompe disease. So pathologically, it's very different. And also, electron microscopic features different. I don't go into the detail about it. Okay, so Danon disease were originally reported as a disease similar to Pompe disease, but clinical pathologically, it's very different. Okay. Okay, finally, as I mentioned, adult Pompe disease, adult onset Pompe disease is very difficult, not just clinically, also pathological, very difficult to make a diagnosis. So I showed this picture before, and this was the only, small tiny vacuole in this particular case. And again, I don't think this is really the Pompe's vacuole. But actually, if you look at this, specimen very carefully, there is something here. Right? It's not Pompe vacuole at all, but some inclusions, right? We focus on this one. And actually, if you do modified Gomery trichrome stain, they look like what we call cytoplasmic bodies. And interestingly, they have acid phosphatase activity. So we have never seen such inclusions. So maybe they are, very specific to Pompe disease. And in fact, if you do electron microscopy, you will see this type of unusual inclusions with autophagic vacuoles inside. Then probably that's why inclusions have acid phosphatase activity. And interestingly, in adult onset cases, okay, 80% of cases, if you really search for very hard, 80% of cases have one or two vacuoles. But 20% of cases don't have any vacuoles, but all cases have this type of inclusions. So we believe that this inclusion, unique inclusion, is more diagnostic or more useful for the diagnosis of Pompe disease on LOPD, on muscle pathology. And this inclusion can also be observed in childhood onset cases. So probably this is, if the disease progresses relatively chronic, you will, for some mechanism, this type of inclusion is developed. Okay, and so again, so the extent of vacuoles is really somehow compatible with the extent of clinical features. But instead of vacuoles for adult cases, this type of inclusions may be more diagnostic and more useful for the diagnosis. Okay, by the way, the number of patients on ERT is currently 19.3 in Japan. So I just obtained this information 2 days ago. And actually, I also obtained the same type of information from Sanofi, staff from Sanofi Taiwan through my former colleague in Taiwan. And then very interestingly, the number of the patients is exactly the same at the moment. Of course, that's by chance, but the population size is 6 times larger in Japan as compared with Taiwan. So actually when they come, when somebody in high position from Sanofi come to our lab, they always say that maybe you missed the diagnosis. Taiwan, you saw many patients, you must look, over some patients. They always say that. Yes, but we have to, prove that we didn't overlook any patients. For this reason, actually we did study, prospective study. So as Dr. Shen introduced, our lab functions as a nationwide referral center for muscle disease. And then like 80% of muscle biopsies performed in Japan come to our lab, and I sign all the cases. So my mentor, Dr. Nonaka, started this service in 1978, and I took over this job in 2000 or 2001. And Dr. Nonaka said that, okay, muscle pathology is, well, it's invasive, and probably, MRI, resolution of MRI will be very much improved in the next 5 years. So probably you can just do muscle pathology for 5 years, and then after that you can do whatever you want. That's what he said, but look at this one. After 2000, for some reason, the number of cases we receive is still increasing, and now we receive more than 1,000 cases per year. Yeah. Anyway, so for this, during this time, so 2.5 years, we decided to screen for Pompe disease for all muscle biopsy samples, everything, all the cases. So during that period of time, we had 2,400 cases, and we make another section, and using this section, we asked our collaborator and to measure GAA activity. And to make the long story short, we found, okay, several cases with a little bit lower enzymatic activity, but all of them had what we call pseudo deficiency allele. Okay, and nobody had. Okay, only one case had mutation in one allele, not in both allele. So it's not disease, right? The only heterozygous. It's this particular case, very, very low, right? But infantile, even adult onset form, it's much lower. But this was the lowest one, okay? This particular case had pseudo homozygous, the pseudo deficiency allele in homozygous mode. Plus, she had heterozygous mutation, which is already reported for infantile onset Pompe disease. So she may develop Pompe disease, right? But muscle pathology is this one, nothing at all. And she was actually, the sample was sent to us and under the clinical diagnosis of Lee disease, Lee encephalopathy, and nothing to do with Pompe disease. Of course, you never know if she, survived like until 100 years, she may develop something, but I don't think she has Pompe disease at the moment. So it means that we have never missed the diagnosis. And interestingly, we checked all the Pompe cases, in our muscle repository. So from 2000 to 2005, 5 years, the ratio of this is adult onset, childhood onset, infantile onset. We had many infantile onset cases. This is almost the same as up to year 2010. But for the next 5 years, look at this one. There is no infantile onset Pompe disease at all. Why? Because enzyme replacement therapy becomes available, and now pediatricians are very well, trained for Pompe disease, and they make a diagnosis without doing muscle biopsy, right? It's so clear. And also the number of childhood onset cases also decreased to half. This is also because of the pediatricians. For the remaining one, adult onset cases. In the next 5 years, we don't find any more cases because now adult neurologists also learned. So pediatricians learned first, then the adult neurologists learned. Then we don't have any cases like this. But it's good actually, right? So the diagnosis can be made without muscle biopsy. And of course, I don't go into the detail, but some papers suggest that myotonic discharge, EMG is very helpful for the diagnosis, but I don't go into the detail. Okay, so this is the summary. So LOPD, okay, of course you have to cast a wider net because it's not really, there is no really characteristic or diagnostic clinical or pathological features, especially for adult cases. So whatever you may, if you see proximal muscle weakness, respiratory failure, or high CK, and if that diagnosis is not made yet, of course, you should do a DBS. And for laboratory testing, I emphasize the importance of muscle imaging. This is very useful. So I believe that the muscle imaging should be done for all muscle disease cases, yes. And muscle pathology is still important and it's useful. And for the diagnosis of adult onset cases, acid phosphatase positive global cytoplasmic inclusions would be more useful. And EMG, I didn't go into the detail, but myotonic discharge is very important. Okay, so we actually made because muscle biopsy and also fixation of muscle, freeze fixation of muscle biopsy sample, it's not that difficult, but need, a little bit, specialized technique. So we made a video. This video is, I praise by myself a lot, but this video is very good, very good. And there is animation and also the real, okay. And this is the acknowledgement. And that finally, we will organize Asian Oceanic Myology Center meeting next year in Nara, Japan. I heard that Hongkongese love to come to Japan. So please be sure to attend and enjoy sightseeing. Thank you very much.
Thank you, Professor Nishino. Maybe Professor Nishino that could take a rest and take some Q&A. I want to ask Professor Nishino, because in some of the meetings, the presenters found the tongue atrophy as the one of the presenting features in some of the Pompe patients. But I seldom see Asian patients with this kind of presentation. Do you have similar experience for tongue atrophy as the unique presentation in Pompe?
Right. Well, I don't see patients by myself, so I can't tell that I can answer it very well. But there are several reports of the MRI change in the tongue. So that may help. They call it bright tongue sign, which was originally reported for the ALS, but that can be seen also in Pompe disease. That may help the diagnosis.
So thank you so much, Professor Nishino. You're always, to me, is an excellent teacher every time. For all the talks you share is always so clear, precise, and explaining all the complicated things with very easy to understand. I love the gait analysis you just show us. I have one question following the question is about one of the slides that you show that the muscle biopsy is increasing throughout the years because your center is receiving the referral from all over Japan. Now, having the example being shown by Pompe's disease, like with the clinical awareness and also maybe with the genetic quick turnaround time with the results, that explained why the muscle biopsy need is less. But the overall actually is increasing. I myself is somebody advocate for muscle biopsy because it can be a lot of information can be done. So can you share more with us the reason behind that?
Yes, thank you for pointing out this point. So actually, I don't know the real reason. Yeah, I'm also surprised. And in fact, in Dr. Nonaka's period, more than, let's say, like 2/3 of the cases are from cases with hereditary muscle disease, like muscular dystrophy, or even SMA. Nowadays, of course, we don't do any biopsy from SMA patient, but previously, they did muscle biopsy whenever you see like floppy infant or whatever. Yes. So, but nowadays, of course, we don't see it. And also, Duchenne muscular dystrophy patients, now genetic testing is widely available. And also in Japan, we have special form of congenital muscular dystrophy, which is called Fukuyama congenital muscular dystrophy. There are so many patients. For those diseases, now genetic analysis is available under our governmental nationwide medical insurance. So they will not receive muscle biopsy, and they will the diagnosis will be made. Many of the cases diagnosis is made, without muscle biopsy. So for sure, the number of muscle biopsies should be decreasing. And that's why Dr. Nonaka said that, okay, I should do just for 5 years and then I can do something else. But yes. And actually I analyzed the final diagnosis of our series. And many of the cases are now myositis. Yes, right. So it's opposite. Now 2/3 or even more the cases are clinically diagnosed with myositis. Yes, and of course there are many interpretations and also hypotheses, but one reason is because Dr. Nonaka is a pediatrician, but I'm an adult neurologist. So maybe more adult neurologists send sample to me, and or also our lab have been studying myositis in the last 10 years or 15 years. So then it may somehow advertise our lab to rheumatologists. So now we receive more samples from the rheumatologists and even from dermatologists. And maybe this is the reason.
Thank you so much. So we have Dr. Hyun.
Thank you, Dr. Nishino, for your excellent teaching. I would like to ask do you think that genetic diagnosis would make things more definitive and also correlate with the long-term prognosis?
Well, is it about Pompe disease or Pompe disease? Yes, yes, yes. I think the mutation and its phenotype is already somehow correlated, and you can somehow tell the prognosis by the mutation. But of course, you cannot, precisely, tell the prognosis until what age or something. It's very difficult, but still, I think there is genetic, so genotype-phenotype correlation in Pompe disease. But when it comes to, well, of course, muscle pathology, for example, and muscle pathology as well, and there is genotype-phenotype correlation. Yes, so for certain mutation, yes, they show much milder phenotype on muscle pathology as well. But when it comes to hereditary myopathy in general, I think it's a little bit tricky. But nowadays, in many countries, like in the US, also in European countries, and then this is also the case, I guess this is also the case in Hong Kong, but there are many, the increasing number of clinicians do genetic testing first before muscle biopsy. Of course, it's okay, but what you get after whole exome or whole genome sequencing, you will receive a long list of VUS, right? Yes, then you don't know what it is, right? Then I think you shouldn't hesitate to do muscle biopsy if you suspect muscle disease, and also muscle imaging. Yes, so it's like previously, before genetic, analysis age, muscle biopsy is really the final diagnostic procedure. But now it's not. Of course, for some diseases, of course, it's not, it can make the final diagnosis. But I think you need everything. I always think like rare disease like muscle disease, we should do everything we can do, because all professors always say that we learn something. We always learn from each patient, right? For rare diseases, I think we should do everything we can do. Of course, we shouldn't do it very much invasive one, but I think we should do everything. Yes, that's how we learn. Yes, right.
Professor, you mentioned muscle imaging. We have a chat question asking what region of MRI should you order? You go for full body or something like that?
Yeah, very good questions. Thank you for asking. Yes. So actually, muscle disease affects all muscles, all of your body. So actually, the best option, which if it is available, is a whole body MRI. Okay, but whole body MRI is not available everywhere. Actually, almost not available anywhere except for some institutes, especially medical institute. So Yes. So for MRI, I think you have to select some regions. Of course, so I think you have to focus on the muscle where you see muscle weakness, first of all, muscle weakness or atrophy. But if, well, the muscle is affected, the upper, lower, maybe, equally affected, then you may want to focus on at least thigh and also hip and calf muscle. Then at least you can, compare. Just I did. So just as I did, you can compare it, the standing maneuver or gait, maneuver to imaging imaging data, and that will be helpful. But it doesn't necessarily mean that you don't have to focus on upper extremities. Shoulder girdles are actually also important, especially for the cases with scapular winging. So I really love to see whole body analysis. But in Japan, unfortunately, whole body MRI is not available. So I asked, especially for the cases suspected to have FSHD, I asked the physician to perform multi-slice whole body CT. Of course, patients will receive a large amount of radiation, but once in a lifetime is okay. If you do it every day, of course, it's going to be a problem, but just one time, okay, I believe that for muscle disease patients, at least one time you should do whole body imaging analysis. That would be very, very useful. Yes.
Any other questions, both here or colleagues joining virtually? Any more questions? Maybe I ask the last question. Did you receive histology comparing some treatment response before and after in your research setting? Usually, we try to focus on similar regions to take the biopsy. Do you find it is difficult to focus on when we doing the research? We want to compare the treatment effect to select one group of muscle to target on for the histology finding?
Yeah, I think one way is to compare, to do muscle biopsy, to do the second biopsy from the same muscle on the other side. If the both sides are almost equally affected, that's one way. Yes, but if you do the second biopsy from the same side, I think you may see abnormality, effect of the first biopsy, right? So I think typically they do muscle biopsy from the other side.
Okay, thank you. Please join me to thank Professor NISHINO for his excellent talk.